Very good evening to all the respected doctors. Myself Sumit Nagpal from Mankind Pharma, and let me share key highlights of our organization. So 2020 is the year when Mankind Pharma has completed 25 years in pharma industry, and our vision is to become the most admired Indian pharma company. We are always committed to improve quality of life, and three pillars of our success are affordability, reach, and quality. We are having strong presence across various therapy areas like anti-diabetic, cardiovascular, anti-infective, and so on. We are having our own R&D center in Manesar, Gurgaon. Their major focus is on new drug discovery and APIs. Being a responsible pharma company, we are always committed to help our employees and frontline health workers by numerous ways. And once again, we thank you, all of you, for your continuous support and encouragement for us. Now, I will hand over the session to Dr. Prashant Agarwal.
Thank you, Samiji. And thank you all our respected audience, who has joined us here in this scientific event where we are having an eminent panel of Dr. Russell Reiter, sir, Dr. K.K. Agarwal, sir, and Dr. Shashank Joshi, sir. Now, it is my privilege to introduce each of the one with you once again. You are already aware who are they. They are the stalwarts of the healthcare industry. So, Samiji, please next slide. Okay, now let me introduce to our speaker, Dr. Russell J. Reiter. He is professor of cell biology at UT Health San Antonio Long School of Medicine, San Antonio, Texas, USA. In addition to his PhD degree, Dr. Reiter has received 4 honorary MD degrees and 1 honorary DSc degree from international universities. Dr. Reiter has received numerous awards for his research, including the A. Ross McIntyre Gold Medal, US Senior Scientist Award, Lizoni Lindsay Award, inaugural Aaron B. Lerner Pioneer Award, and Chulalongkorn Royal Academy Medal Award, and so on. Based on Google Scholar, his paper have been cited in the scientific literature more than 159,000 times. That is really a very big number. The Web of Science has identified Dr. Reiter as a highly cited scientist among top 1% globally and listed him as one of the world's most influential scientific minds in 2014. Welcome, Dr. Reiter. Now,
Thank
let
you.
me move ahead to introduce our panelists of this evening. First panelist, Dr. K.K. Agarwal, sir, recipient of 4 national awards, Padma Shri, Vishwa Hindi Samman, Dr. B.C. Roy National Award, National Science Communication Award, and 1 state Delhi Hindi Sahitya Sammelan Sahitya Shri Award 2007, Doctor and Philosopher of Indian Culture. He has to his name 3 Limca Book of Record in CPR 10. He is gold medalist, TEDx speaker, and recipient of FICCI Healthcare Personality of the Year Award 2016. President of Confederation of Medical Association of Asia and Oceania, also President of Heart Care Foundation of India. He is Group Editor-in-Chief of IJCP Group, past National President and past Honorary Secretary General, Indian Medical Association, past President, Delhi Medical Association and IMA, New Delhi branch, former Ethics Committee member, Medical Council of India, and former Chairman, Ethics Committee, Delhi Medical Council. Welcome again, sir. Now, let me move to our next panelist, Professor Shashank R. Joshi, sir. He is Chair of the International Diabetes Federation, Southeast Asia region, Dean of the Indian College of Physicians, endocrinologist at Joshi Clinic and Lilavati Hospital, Mumbai. He is also the member of the COVID-19 Task Force. He is editor of Practical Medicine, a popular undergraduate Indian textbook, and editor emeritus of the Journal of the Association of Physicians of India, and has been the editor of 3 prominent Indian journals, namely Indian Journal of Obesity, Indian Journal of Endocrinology and Metabolism, and Indian Journal of Clinical Pharmacology and Therapeutics. Dr. Joshi is a prolific writer of articles on diabetology and endocrinology and has published more than 100 books and monograms and over 800 research publications on topics such as diabetes, obesity, thyroid disorder, osteoporosis, and growth. Welcome, sir. Now I hand over this session to our speaker, Dr. Russell Reiter.
Thank you. Thank you very much for your kind introduction. Obviously, I'm going to talk about melatonin in relation to COVID, and I want to make the strong point that we're talking about prevention and treatment, of course, of this debilitating disease. SARS-CoV-2, of course, is an unwelcome guest that has arrived within the world community within the last year. And we have a molecule endogenously produced called melatonin. Most people realize or know that it's produced in the outgrowth of the brain called the pineal gland, but in fact, that's only a small percentage of the total melatonin that is produced in the body. And we will review that during this presentation. This is a mock diagram of some of the molecular pathogenesis of the SARS-CoV-2 infection. Primary in this is angiotensin 2, which is converted by its enzyme to angiotensin converting enzyme 2 to angiotensin 1 through 7. This is a vasodilator and activates the macrophage activation syndrome, which induces reactive oxygen species, and reactive oxygen species or free radicals are consequential in much of the damage that is done in this serious condition. Angiotensin 2 also acts on its receptor and stimulates oxidases. Oxidases are notoriously good also at activating or stimulating the production of reactive oxygen species or free radicals. Reactive oxygen species then have direct inflammatory actions and via an interacting protein stimulate the inflammasome, which also contributes to inflammation. Additionally, reactive oxygen species activate nuclear factor kappa B, which translocates to the nucleus, binds to DNA, and generates pro-inflammatory cytokines, which again stimulate the inflammasome. And this hyperactivation of this system leads to, of course, severe inflammation and what is referred to as the inflammatory cytokine storm. Now, what happens at that point is the inflammatory storm also, because of the damage it does, stimulates additional free radicals. So this becomes actually a vicious cycle, and it's difficult to interrupt. And consequently, it accounts for the hyperinflammatory response associated with that virus. This is again another diagram illustrating that the initial lesion, when the virus is inhaled, is at the level of the alveoli in the lungs. There's two types of cells lining the alveoli, type 2 pneumocytes and type 1 pneumocytes. It is type 2 pneumocytes that in fact contain most of the ACE2 enzyme and allows the virus to get in. In response to that, these cells release attractants, chemical attractants, such as monocyte chemoattractive protein 1, and that permits or recruits monocytes to be attracted to the lung, and they transfer into inflammatory macrophages, in this called type 1 macrophage. There is another type of macrophage that I will mention earlier. It stimulates a lot of very serious events in the inflammatory cells, such as when the virus enters, it activates, of course, caspases, and again, inflammatory molecules that cause free radical generation. Of course, the free radicals also cause oxidative stress, and oxidative phospholipids are rapidly produced. They act on what is called a trail receptor and of activating again the NF-kappa B pathway, which activates inflammatory genes and so forth. Additionally, there are other cells involved, natural killer cells and activated T cells, which release granulocyte macrophage colony stimulating factor, which works on receptors to stimulate Janus kinase, an enzyme that stimulates staph, and it also causes the production of molecules that are cause inflammatory. Interestingly, my colleague just this morning pointed out a study being done in the United Kingdom where they advise that drugs that inhibit JAKs would probably be very beneficial in terms of reducing the inflammatory response. And melatonin is, in fact, a JAKs inhibitor. This is a summary of what I've been saying so far. Here's the alveolus in the lung. It's aligned by type 1 and type 2 pneumocytes, and it's the type 2 pneumocytes that contain the ACE2 receptor or the enzyme. It causes, of course, the production of cytokines and chemoattractants, which attract the macrophages, neutrophils, and other cells that become part of the inflammatory response. Of course, they also do some damage, and this molecular debris accumulates in the alveolar sac. You additionally have edema from the surrounding capillaries, and you get some hyaline membrane and fibrin accumulation, congesting the individual alveolar sacs and contributing to the hypoxemia, which is common. It interferes with the exchange of oxygen with carbon dioxide. Now, the activated macrophages, they become activated, I mentioned, by the macrophage activation syndrome, and they and other cells, neutrophils as well, generate cytokines and chemokines, which produce more free radicals and do additional damage. As mentioned before, this becomes, in fact, a cyclic process. The respiratory damage culminates eventually, if it gets severe enough, in acute respiratory distress syndrome, or ARDS, and there can be fibrotic complications if the disease persists. And we're going to talk about the fibrosis that is a consequence as well. Due to its antioxidant and anti-inflammatory actions, actually now this has been increased to 35. There are 35 different publications that have suggested the use of melatonin as a treatment for COVID-19 infection. Of course, the free radicals are numerous. Most of them also free radicals and reactive oxygen species. In this lecture, I'm equating those two. Most of them are derivatives of oxygen. A single electron reduction of oxygen generates a superoxide anion radical. It is dismutated, enzymatically dismutated to hydrogen peroxide, and then in case of the Haber-Weiss reaction, the hydroxyl radical is formed. This is a very serious situation in that the hydroxyl radical is extremely reactive. It's estimated that perhaps as much as 60% of total oxidative stress that cells sustain is a consequence of the hydroxyl radical. Additionally, superoxide anion couples with the gaseous neurotransmitter nitric oxide to generate peroxynitrite anion. It has no unpaired electrons. This represents an unpaired electron. And it has no unpaired, in other words, it's not a free radical, but it's a strong oxidizing agent, and in fact, seemingly equivalent to the hydroxyl radical, and may in fact degenerate into the hydroxyl radical. Represented by these asterisks here are the molecules that are, or partial molecules that are scavenged by melatonin, and you notice melatonin functions as a potent direct free radical scavenger. Additionally, melatonin is a stimulator of antioxidative enzymes, superoxide dismutase, which removes superoxide anion, preventing its coupling with nitric oxide to hydrogen peroxide. And then hydrogen peroxide is removed by catalase and glutathione peroxidase, both of which are also stimulated by melatonin. So melatonin has direct scavenging activity and indirect activity in removing these free radicals from the system. There's strong rationale actually for the use of melatonin to treat these viral diseases even before COVID-19 came on board. For the last 30 years, scientists in Europe, for example, have looked at various viruses in response to melatonin. Now, these are all animal studies, but I suspect some of that information applies to human. Encephalomyocarditis virus, if you give it in combination with melatonin, it prevents the paralysis and death of the mice. Semliki forest virus likewise prevents the death of mice. West Nile virus, which is commonly known throughout the world, causes encephalitis and death, and it is reduced also by melatonin. This disease work was done by Georges Maestroni, Ariel Conti, David Ben Nathan, and other scientists in Europe. In South America, Venezuelan equine encephalomyelitis virus, which is transmissible to the human, has been investigated, and it too, melatonin decreases the viral load and the death of animals when it's injected. Aleutian mink disease virus is a virus that causes the premature death of mink. Mink are a common or an important commodity throughout the world because of their fur, and this virus kills a lot of mink, and it is prevented also by melatonin. Even in plants, and melatonin is present in plants in higher concentrations generally than it is in animals. I'm not going to discuss that, but even in plants, rice stripe virus, the degree of resistance to this virus correlates with the melatonin concentration of the plant. So the rationale is strong that you would anticipate that melatonin would in fact be beneficial. Here's what we think is happening. Of course, the monocyte is from the center of the bones, in other words, myeloid elements, and they can be transformed into macrophages. The type 1 macrophage, which I showed you previously, is in fact highly pro-inflammatory and releases a wealth of chemokines and cytokines that in fact initiate the cytokine storm. Very important aspect of the disease of COVID or SARS-CoV-2. Additionally, there's another type of monocyte called the macrophage called the M2 macrophage, which is actually anti-inflammatory, releases molecules that only impact inflammation slightly. We now know that melatonin converts M1 to MT macrophage, in other words, converts a pro-inflammatory macrophage to an anti-inflammatory macrophage. And the way it does this is by changing its metabolism. The M1 macrophage produces ATP via what is referred to as the Warburg effect. The Warburg effect is commonly known in cancer cells, but is also now known to be present in other disease cells. And melatonin prevents the Warburg effect, converts them to oxidative phosphorylation, and the form of the M2 macrophage, which is very important in reducing the disease. Treatment with COVID is in fact protective, as you're going to see. And of course, we're going to talk briefly about fibrosis. But the important thing is here, melatonin converts M1 macrophages to M2 phenotype, which reduces the inflammatory disease. Now, of course, everyone knows that you have melatonin endogenously in your body. It's released from the pineal gland, particularly during the night. There's very little melatonin in your blood during the day, but at night, depending on the activity of the pineal gland, melatonin levels increase, and this imparts a lot of information regarding circadian rhythms and other effects. The interesting thing is there are some people who have a relatively low nocturnal peak, suggesting that they produce significantly less melatonin at night than others. And we believe these would be more susceptible to a serious COVID infection, albeit that has not been totally established. There are some individuals, either for genetic reasons or related to melatonin, that we know even at a younger age may be highly susceptible. The blood melatonin rhythm does not occur until or appear until 4 to 6 months after birth. Its highest amplitude occurs during childhood, and children seem to be relatively resistant to a serious COVID-19 infection. But melatonin levels diminish markedly with age, such that in the aged or the elderly, melatonin levels are in the blood are barely distinguishable. We'll discuss that later. Many diseases, for example, HIV, AIDS, are associated with reduced melatonin levels, which you would predict. These individuals are generally referred to as being hypomelatonemic, and they are not easily identified because to identify them, you have to know the nighttime levels of melatonin in the darkness, and rarely are they measured. The other source of melatonin in all cells, in every cell in the body, is in the mitochondria, and this was only recently discovered. Normally, glucose, of course, is a fuel for all cells. It's converted to pyruvate, and pyruvate is transferred into the mitochondria, where it's converted to acetyl-CoA. Acetyl-CoA is in this a very important factor to stimulate or enhance the citric acid or the tricarboxylic acid cycle, which feeds reducing agents to, of course, the electron chain and enhances the production of ATP. This is what occurs in normal cell. After hypoxemia associated with a serious COVID infection, a hypoxia is recognized by this transcription factor called hypoxia-inducible factor 1 alpha. It stimulates an enzyme, pyruvate dehydrogenase kinase, which is a strong inhibitor of pyruvate dehydrogenase complex. So in these cells, pyruvate is not associated with the generation of acetyl-CoA, and what happens is pyruvate is metabolized in the cytosol, and this phenomenon, as I mentioned before, is referred to as a Warburg effect, and is very common in cancer cells and some other disease cells as well. The interesting thing is that acetyl-CoA, we now know, is also a cofactor for the enzyme that regulates the melatonin production in the mitochondria. The enzyme of concern here is NAT acetyltransferase, which converts serotonin to N-acetyl serotonin, which then is synthesized as melatonin. In other words, without this pathway, in these disease cells, such as COVID infection, this enzyme is inhibited, does not allow for the production of melatonin, and that is very serious. And that's why when you give melatonin and you convert these cells, destroy Warburg metabolism, convert them to oxidative phosphorylation, melatonin is very advantageous. I will talk about that role of melatonin slightly later. For the time being, it's noteworthy that hypoxemia is very bad in that it activates this transcription factor, which eventually culminates in the inhibition of acetyl-CoA production and interferes with mitochondrial melatonin synthesis. There are a number of clinical trials going on throughout the world in reference to the use of melatonin. There are at least 7 that are registered, and there may be others ongoing as well. We are currently performing one in Manila in the Philippines. It's called the MAC-19 Pro trial for the treatment. This is for the treatment of hospitalized patients who are relatively seriously ill with COVID. We have only done a few patients today, but I'm going to identify what we have found. The MAC-19 Pro trial included initially 10 patients. This is all we could get approval to use. 10 patients admitted to the Manila Doctors Hospital between March 5th and April 4th with high-risk features for COVID. They were given 36 to 72 milligrams per day in 4 doses, divided doses spread over throughout the light period in particular. 3 had moderate Rs, 1 had mild Rs, 7 were positive for COVID, and 3 were very likely had COVID, but we could not prove it in terms of measuring the viral load. The observations, all 10 patients given high-dose melatonin. We're going to talk a lot about the amount of melatonin that is required. the specific dose that is required for these clinical situations is not yet significantly determined, albeit it has to generally be higher than circulating levels. Of all 10 patients giving melatonin showed clinical stabilization and improvement, and this occurred within 4 to 5 days. All the patients, including the ARDS patients, survived as a consequence of the treatment, and none of them required mechanical ventilation. Of course, when they have to be mechanically ventilated, that's usually has a very poor outcome. 7 of the COVID patients were discharged, of the COVID positive patients were discharged after a period of 8.6 days. Of the 3 highly probable COVID, they left the hospital in 7.3 days. And those individuals not given the controlled subjects, which is hard to justify controls when you have a molecule that you know is effective and you don't use it because you want to have some control. So this may even be unethical in a sense. At any rate, they are not given melatonin. They left the hospital after 13 days. So clearly, the duration of stay in the hospital was reduced. Additionally, for perspective, simultaneously, there were other COVID patients in the hospital were unrelated to the ongoing study, and 12 of 34 were COVID positive, and of course, they did not receive any melatonin, and 12 of 34, 35% of them died. 7 of the 34 required mechanical ventilation. 6 of 15 non-melatonin treated animals that were confirmed by RT-PCR, but probably COVID-19 also died, and 4 of 15 required mechanical ventilation. So the difference was quite remarkable between the non-treated individuals and those given melatonin. No significant serious side effects were known of the high-dose melatonin except for sleepiness. Sleepiness, you would anticipate. Melatonin has also been espoused as a sleep-promoting agent, but this was deemed favorable by virtue of the fact that sleep is generally considered regenerative in individuals who are sick. So this is the only noteworthy thing that was noticed, and this may be in part related to the fact that the individuals knew that melatonin was in fact a sleep-promoting agent, so they described themselves as being sleepy. Now, as important as these studies may be, and there are other similar ongoing studies like that, we think now that is the wrong approach. What happens is there are, as you all know, there are so many patients that develop COVID that they overcrowd the hospital, and of course, you get exhaustion of the healthcare system, not only of the individuals who are treating them, but of the hospital facilities. Facilities themselves are overwhelmed. It's important that you shift the front lines to the community level. In other words, if there's any way you can prevent the patients from going or ending up in the hospital, that would be important. And I think that's where mankind really has a great idea, in that if you can get the community physicians to work and give melatonin at the appropriate dose and time when diagnosis is made, maybe we can, in fact, reduce the number of people that are hospitalized and, of course, reduce healthcare system exhaustion. This is our current approach. Interestingly, the president of the Philippines, Duterte, advocated or supported the use of melatonin in COVID and recommended for our trial that the study be done and the melatonin be paid for by the government. Melatonin is not an expensive molecule compared to those that are conventionally used, such as remdesivir. It's a fraction of that. I mentioned that hypoxemia is, in fact, a serious aspect of all COVID-infected patients because the lungs become congested and they cannot exchange oxygen for carbon dioxide. But in patients with hypoxemia diagnosed, even if still unconfirmed with a lung findings, as soon as possible, in this study, we gave 100 milligrams initially, and day 1 through 7, we gave up to 400 and sometimes 600 milligrams. Again, I want to stress strongly, I'm not sure, and we are not sure that amount of melatonin is actually necessary. We want to make sure we gave enough in these studies, but it's also always given in divided doses. Again, later in the infectious state, you continue with reduced levels, but high doses, and even after 2 weeks or 3 weeks, you give less, and eventually you get a stabilizing dose of 6 milligrams. So this is done as soon as the patient arrives at the physician's facility and is considered to have or actually diagnosed. The important aspect of melatonin is widely used throughout the world for various reasons, and it has essentially no toxicity. So even if the patient doesn't have COVID infection, melatonin may have other benefits. I noticed Dr. Jossi, I think he said he was interested in diabetes. Melatonin is widely used as a diabetes treatment because it prevents the oxidative stress associated with hyperglycemia. If you have mild ARDS, the treatment is similar. But again, we gave as much as 600 milligrams with no side effects, 600 milligrams per day. Again, I don't think these doses are an absolute requirement. It may be that 50 milligrams would be adequate. And in fact, I'm going to show you evidence for that later. With moderate to severe ARDS, again, the treatment procedure was similar. And in this scheme, we were able to also reduce the individual or the number of individuals that were hospitalized. So high dose melatonin was a beneficial role in patients treated for COVID pneumonia in terms of shorter time of clinical improvement, less need for mechanical ventilation, no or shorter hospital stay, and lower mortality. Every aspect that we measured, and like I say, this is not unique to us. There are a number of ongoing clinical trials where they found very similar effects. In reference to dose, you have to remember that the bioavailability when it is ingested is widely divergent depending on your gender, according to what have you have eaten recently, and the amount of materials that are in your digestive tract. So when you give even 600 milligrams of melatonin, no one has measured the blood levels of melatonin, but it doesn't make any difference. Even if they're exceptionally high, which in animals have no toxicity, you cannot kill an animal by giving them too much melatonin. No lethal dose has ever been identified, and there's no drug that you can say that about. Melatonin is an uncommonly safe molecule. I want to mention this individual. Dr. Richard Neal is an internal medicine physician here in my city of San Antonio, and he has treated nearly 1,000 patients for COVID-19. When they come to his facility, if he diagnoses them with COVID, he immediately begins treating them with melatonin, 1 milligram per kilogram body weight, usually around 50 milligrams rather than the very high dose I mentioned, divided in 2 doses. And treatment is initiated as soon as diagnosis is made. Treatment duration is for 5 to 7 days. Of the nearly 1,000 patients treated, 4 were hospitalized and none were intubated and none died. In other words, he has severely limited the number of individuals that end up at the hospital. And this is very important, again, for preventing exhaustion to our healthcare system. And not only that, preventing the financial losses associated with confinement to the hospital for various durations. His patients ranged from age from 5 to 91, obviously they were skewed toward the lower end. There were more people at the higher, older stages by virtue of the fact that the disease is more manifested in the elderly population. There are known 6 other trials, ongoing trials. There's one in Spain where they're giving melatonin intravenously. But again, given intravenously, the bioavailability is 100%. And of course, you give a lot less melatonin under those conditions. In general, 1 milligram per kilogram or even half milligram per kilogram is in the ballpark where we think it will be effective in terms of reducing. And this is done, like I say, at your office level, such that you can reduce the number of individuals that actually go to the hospital. Of course, there are a lot of neural consequences. There are cardiovascular consequences. There are hepatic consequences. Neural consequences also have been examined, and they exhibit a cytokine storm. The blood-brain barrier is interrupted, and of course, this accounts for the loss of smell and taste. And of course, and if persistent, it causes cognitive decline and brain fog. There are long-range consequences. Even if the disease is successfully treated, there may be long-range consequences. Of course, the virus enters the nasal passage and absorbed by the olfactory mucosa, because they contain some ACE2, not too much, but they contain some, transferred to the olfactory bulb, the olfactory tract, and in fact to the lateral olfactory sphere and the olfactory centers. Additionally, it's never been shown, but of course, the taste buds are modified neurocells, and they may also take up the virus and transfer it to the center, accounting for the loss of taste and olfaction. And of course, it's not uncommon also that there is a very common, of course, headache. Long-term neural consequences, as I mentioned, cognitive decline and brain fog. In the case of the lungs, it's fibrosis, or even in the liver. A lot of tissues become fibrotic over time, and fibrosis is known to be one thing that is markedly inhibited by melatonin. Now, again, no long-term COVID-treated patients have been tested for loss of a reduction in fibrosis as a consequence of melatonin treatment, but I certainly predict that will be the case. SARS-CoV-19 infections have, of course, affect a lot of different organs, and there's a lot of comorbidities that is known. Again, diabetes, heart disease. It's estimated that 30% of the individuals who develop serious COVID have underlying heart disease as well. And one consequence, of course, is the congestion of blood vessels by microthromboses, very small blood vessels. Remember, I showed you on the original slide that fibrin was produced. Melatonin inhibits prothrombin, which converts fibrinogen to fibrin to prevent those microthromboses. In fact, we know in other disease states, such as cardiovascular disease, melatonin is very effective in inhibiting microthromboses, although that has not been specifically studied in COVID patients. There's good reason to believe, because melatonin has the same effects in all these situations. It strongly inhibits oxidative stress, and of course, inflammation as a major part. I think this is a very important slide. Melatonin protection against COVID-19 is not directed to the virus. It is not virucidal. It may reduce entrance of virus into cells somewhat, and it may reduce viral replication. There is study for those two, but it does not kill the virus. The primary effect of melatonin is not directed at the virus. And why this is important is that melatonin protection is directed at regulating host defenses. It stimulates the immune system. It reduces oxidative stress, reduces the cytokine storm, reduces the molecular damage associated with free radical. And why this is important is there are many, as you saw, viral diseases that have common symptoms. I mentioned the 6 or 7 viral diseases before that are reduced by melatonin. And what this means is, of course, a vaccine is specifically directed to one virus. Melatonin, we think now, will be usable for many different viral infections. Again, that has not been, well, there's some evidence that that is true, at least in animals. Because melatonin stimulates host defenses, it may be useful for treating other viral infections, particularly the seasonal flu. We have, in fact, identified and published a report suggesting the use of melatonin for influenza. It's a viral condition. Risk factors for COVID, of course, advanced stage, they have the lowest melatonin. Whether that's directly related or indirectly related to the severity of the infection is unknown. Comorbidities, gender, females usually a bit better protected than males, and children are less affected by COVID infection, but they have the highest melatonin. Again, there's no assurance that the higher circulating melatonin is in fact exclusively responsible for the reduced severity of the infection. Pregnancy provides some protection. During the 3rd trimester of pregnancy, melatonin levels typically increase markedly, and that may afford some protection as well. Herein lies part of the problem, of course, endogenous melatonin, both in the pineal gland and the mitochondria, gradually diminishes with increasing age. This is representation of blood levels of melatonin at night as you grow old. And in fact, we now know that these individuals are most susceptible. And again, whether that's only or exclusively related to the loss of melatonin is not known. Less than 5% of the total melatonin is pineal derived because every cell, mitochondria of every cell produce melatonin, but not when they are infected with COVID, because the hypoxemia shuts off melatonin synthesis in the mitochondria. And that may be one of the very serious consequences of a COVID infection. The hypoxemia activated hypoxia-inducible factor, which inhibits melatonin production in the mitochondria. Here's a summary, simple summary. Melatonin is useful in combating COVID-19. It can be taken by any route. You can take it, typically it's swallowed orally, but it can sublingually. The study I mentioned by Dr. Neal, where he has treated 1,000 patients, he thinks that sublingually melatonin may be a little bit more effective, and that could relate to its better bioavailability. When you use it orally, of course, it's absorbed by the gastrointestinal tract, goes immediately to the liver. Liver functions as a detoxifier or changing of everything. If you put it sublingually, it avoids the first pass effect. But it can be given intravenously, intranasally, it's been given transvaginally, it's been given rectally with very similar effects. Melatonin, in fact, reduces the cytokine storm and oxidative stress, the 2 main features of a COVID infection. And I mentioned cytokine storm induces oxidative stress. Oxidative stress aggravates the cytokine storm. So this circular pathway has to be interrupted. The damaged alveoli, of course, are a consequence of one aspect of a COVID infection. Many organs can be involved and they become septic and die from sepsis. We already know that bacterial sepsis in humans, we published a report already in 2001 showing that in premature newborn humans, when they become septic, if they are treated with high dose melatonin, 80 milligrams for a 1 kilogram baby, that in fact will prevent the death of those patients. Of course, the culprits in all of this are the macrophage activation, neutrophils, activated T cells, all of which generate the cytokine storm and contribute to the disease of the lungs. I want to make an argument in favor of melatonin for this reason only. First of all, there's been 2 studies within the last 3 weeks, that are very relevant to this. Zhao et al. At the Cleveland Clinic in the United States published a report where they took the data of all COVID patients who have been treated with drugs and did a network analysis and determined which drugs would probably be the best on the basis of all the published data. And their conclusion was that melatonin is potentially the best for the prevention and the treatment. Again, someone's going to ask me, obviously, do I take melatonin? I obviously do, and I have taken it for, and I'm taking it to prevent. In other words, maybe melatonin should be given to susceptible populations just to prevent even before treatment. Like I say, melatonin has no toxicity of any significance, and therefore there's no reason not to use it. So they suggested that melatonin was the best drug to take, and they had no vested interest in melatonin. They were not melatonin scientists. Ramlal, who happens to be an Indian guy, his first name is Vahindra, and he is at Columbia University Medical School in New York, and they also found that melatonin exposure caused a positive outcome in COVID-19 patients who are mechanically ventilated and given oxygen. In other words, they deduced, very similar to Zhao, that the best molecule to use to treat these COVID-19 patients were melatonin. And again, they had no vested interest in melatonin. They had not previously published on melatonin. And I'm going to use this argument as a consequence to explain why I think melatonin should be used. Melatonin should be used in the context of what is called Pascal's wager. What Pascal says is, if you have, he's a physician, he's a mathematician, he's no longer surviving, but he said, if you have a molecule that is effective, it should be used if it doesn't have any toxicity. And melatonin doesn't have any toxicity. It should be used even though it's not proven as an effective treatment. For example, if you take melatonin and it works, in fact, you will improve your health. But if it doesn't work, it doesn't make any difference by virtue of the fact that melatonin doesn't have any toxicity. But if you don't take melatonin and melatonin actually works, the outcome may be, in fact, significantly worse. So using that argument alone, a molecule that has no known toxicity, that may work against COVID, and not only that, the evidence suggests it does, it should be taken as a preventative and as a treatment. President Trump of the United States was, of course, infected with COVID, and you'll notice he was also given melatonin. In other words, they were confident enough in the melatonin data to give him melatonin, along with a cocktail of other molecules. And that's not uncommon. It's not uncommon to treat with a number of different. In addition to seasonal influenza, I've already mentioned that, the possibility of using melatonin to reduce the severity of it. 4 epidemics or pandemics in the last 2 decades: SARS, MERS, Ebola, COVID. There will be others. And this is where melatonin becomes important. Melatonin, I want to stress, is not directed at the virus. It may have some antiviral effects in terms of replication, but what it does is improve the host response. Of all the repurposed drugs that have been studied, melatonin is frequently recommended as the one that will be most effective. Vaccines are great, obviously, and will help to alleviate the COVID disease problem, but it is directed toward a single virus. As soon as we get a new viral infection, we'll have to develop another virus, and another vaccine. I want to remind you that melatonin is extremely inexpensive. Remdesivir, it's estimated for those people who are treated for 5 days, costs in American dollars about $2,500. For melatonin, that may be as little $10 to $20. So if the effect of melatonin is as it seems to be, it should be used as a prevention, as a treatment. I have no conflicts of interest. I have no patents. There are many patents on melatonin. Melatonin use is been patented for almost anything. 100 different patents. I have none. I have no conflicts. Melatonin is inexpensive, does not require refrigeration. Again, the vaccines have to be kept extremely cold and may, as a consequence, not be accessible to many people. The Pfizer Corporation in the United States announced yesterday in the United States, they will start delivering their vaccine for use, but it has to be shipped in ultra cold containers and also kept in that cold environment until its use. So this is another advantage melatonin has. It doesn't require refrigeration. Melatonin can be self-administered, taken orally. I've taken it, like I say, for 27 years, and no overdose has ever been reported. And it can be administered by multiple routes. Melatonin use in COVID, I think, could eliminate or reduce healthcare exhaustion and offer alternative to vaccines. Like I say, not everyone will have access to vaccines immediately. I thank you for your attention. I thank Mankind Pharma for this opportunity. Thank you very much, ladies and gentlemen.
Thank you, sir. Thank you for this enlightening lecture. Now the session is open for the discussions. So I will take comments from Dr. Shashank Joshi, sir, first. So any comments?
So I completely agree with Dr. Russell Ritter. In India, I have been using melatonin for the last almost 20 years. And we have 3 milligram available. I'm happy that Mankind also has it available now. And it is a wonderful drug. I have used it in many diseases beyond just a simple jet lag. And in the COVID, probably I have more than now 1,000+ cases where I have used melatonin and successfully in home-based care. And I have also used it and I have continued usage of melatonin for almost 90 days to 120 days after COVID, because it is very useful for the post-COVID syndrome also. It is not just an anxiolytic, it is a neuroimmunomodulator. And because it is a neuroimmunomodulator, it clearly boosts the innate host immunity. And Dr. Russell has very scientifically shown that. But we have used it in clinical care. My mentor and teacher, Dr. Agarwal, also has used, I think, melatonin quite effectively. It serves multiple purposes. It serves as a preventive prophylactic. It serves as a treatment agent in mild, moderate, severe. It serves as a recovery option. It also, to a great extent, reduces the post-traumatic stress disorder which people get, and also for the neuro-COVID which comes up later, it is preventive. So I think I am a great believer of melatonin as a perfect adjuvant. The doses we have used are not high. So in moderate to severe cases, we don't have too much of experience with melatonin. We need to do that data piece here. But in mild cases, in home isolated cases, and in post-COVID recovery syndrome, we have a large wealth of information of more than 1,000 cases where we have used it. And Dr. Ritter, I'll write to you, and so will Dr. Agarwal, and we'll see whether we can pool our cases and show it to you, and then probably publish them from data from India on melatonin and COVID. Dr. K.K. Agarwal.
That would be absolutely great. I'm delighted to hear what you say. And again, you mentioned something that is very important. How much melatonin is required? I think any melatonin will be good melatonin, so that you cannot go wrong in treating individuals with melatonin, and you cannot overdose. So you can try a number of different regimens for different individuals. But again, what you say is exactly what Richard Neal found in the 1,000 patients he treated. It keeps them out of the hospital. You mentioned community care, office-based care, and that is very important for the healthcare system. And if I don't know the situation in India or who pays for all the hospitalization, but again, hospitalization is very, very expensive. So if that can be avoided, and melatonin is efficacious and saves their lives, it's well worth the investment.
We use 3 milligram, 1 to 3 tablets. So it is from 3 milligram to 9 milligram. That's the dose we have used. Dr. Agarwal.
So of late, my interest has been a lot on prevention. Specifically, if one person is suffering, everybody in the family is asking what to give. We have been debating over hydroxychloroquine, ivermectin, and now we are talking about melatonin. Here, you, Dr. Russell, Dr. Shashank, and myself, we can come back with, because there is no data as on today in India. And so therefore, we can build it up this into a small mini expert committee meeting. And we can come back with a recommendation on a prevention dose and a treatment dose. So which can be certified by 3 of us. Later on, more people can get added and do that. So what do you think can be the prevention dose? People who are having a close contact with a COVID positive patient, how much milligram of melatonin should be given to them? Because these are the people who may be having COVID, may not be having COVID. So do you have any protocol for prevention? How many milligram? Is it still 50? It can be less. Because for a treatment, patient will go, we want a minimum dose effective for prevention. Russell.
You mentioned hydroxychloroquine. There is one clinical trial going on with melatonin in combination with hydroxychloroquine. I think that is also a reasonable approach, although hydroxychloroquine itself has kind of been dismissed as being beneficial. The most commonly mentioned drug, at least in the United States, is remdesivir. But there are no trials going. I think melatonin given in combination with these drugs would also be very important by virtue of the fact that these drugs typically have toxicity. That's why they have to be prescription. And in fact, it's very well known, and there are many publications showing that the toxicity of most drugs, particularly at the level of the liver, are a consequence of the fact that during their metabolism, they generate free radicals, and melatonin protects against that damage when it occurs as a consequence of. In terms of the minimal dose, like I say, that's a very good question, and that has not been established. But again, I would say for maintenance or for prevention, maybe 20 to 30 milligrams daily, exclusively at night. But after a diagnosis is made, you may want to up that slightly and give it in divided doses during the day, so you continually suppress the inflammatory response. You have a very legitimate question. Minimal effective dose. That has not been established. All the clinical trials that I've seen, including ours, we use very large doses to be sure we exceed the minimal effective. But as I mentioned, I don't think 300 milligrams.
What can be the dose for India as far as prevention is concerned? Both of us can pick up patients, do a combined trial.
So I have, sir, used 3 milligrams, and I use 3 milligrams quite effectively. And I think if there is mild COVID, you can go up to 6 milligrams. And if there is moderate COVID, go up to 9 milligrams. And I have actually data which I can share with you of probably computerized database of 2,900 patients, where I can actually show that 3 milligram has done extremely well. And you can upgrade it right up to it. In post-COVID syndrome, I have gone up to 3 tablets, particularly people who are having severe fatigue and this so-called brain fog, memory loss. They just don't feel normal, and they are the ones who have had some dramatic relief with 9 milligrams. So I usually use post-COVID a little larger dose, and in the pre-COVID or during COVID, in mild cases, I use up to probably 3, and I think in moderate COVID probably 6 to 9 milligrams. In severe COVID, as I said, you definitely need to give at least 6 to 8 tablets minimum. So at least give that dose in through a Ryle's tube, particularly if the patient is in the hospital, if he's not eating orally or she's not eating orally. So that's what we are trying to do here.
I only want to say one thing.
Yes.
I only want to add one thing is that in COVID, we are seeing a lot of thermoregulatory dysfunction, which is causing hypothalamic involvement, leading to low-grade fever lasting for 3 to 4 months. And here I'm showing is when it can cause a thermoregulatory dysregulation at the level of hypothalamus. It is also causing a chronological dysfunction where we get something like a jet lag phenomena. The post-COVID may be something like a jet lag, and it is causing disruption of the chronological phenomena in the body. Therefore, melatonin is helpful. And the third way we explain to the people is imbalance between serotonin and melatonin. They are opposite to each other. Serotonin is inflammatory, melatonin is anti-inflammatory. So therefore, whenever you have more inflammation, you need to reduce serotonin and increase more melatonin in the body. This is how when we explain, people get convinced much easier, because when we start talking about at a level of cell, people will clap and say very good, but they may not be able to understand. But this is how I make my people understand is a ratio of serotonin versus melatonin. Serotonin increases inflammation, melatonin reduces inflammation. And if you can have a dysregulation of your hypothalamus, similarly, you have dysregulation of a pineal and pineal-like glands, every cell, where your chronological function is impaired. And everybody knows that melatonin is given in a jet lag. So I say there is a cellular jet lag produced by COVID-19, which needs to be controlled by giving melatonin.
Thank you for that comment. You're absolutely right. Certainly, there's some circadian disruption as a consequence of COVID, or as you say, and melatonin is a circadian rhythm synchronizer. I'm also very pleased that Dr. Agarwal mentioned the hypothalamus. The fever associated with this condition is a consequence of adjustment of the hypothalamic set point temperature. We know that set point temperature, that thermostat, is in the hypothalamus. And in other cases of fever induction, melatonin will reduce fever. So it may be its action on the hypothalamus, on that specific set point temperature, that is allowing melatonin's efficacy in terms of reducing the fever.
So I only want to add one thing is that I liked the message of the day for the people from my side is very clear. If a drug is not harmful, may benefit, there is evidence it may benefit, it makes sense to give it. Any drug which is not harmful may benefit, there is justification for giving it to the people. That's my take-home message from Russell.
So I think I would also make a similar comment that Dr. Russell has given us a very good insight. And I think it's a very simple drug to use, usually except for a little mild headache, no other side effects. And it resets the biological clock. Every body cell has a clock. And COVID disrupts all the clocks in every cells. So the way I explain to my patient is that it is like a clock resetter. So, you know, the COVID unwinds the body clock, and melatonin rewinds the body clock. And when I explain it to them in such a simple way, and also reduces a lot of anxiety, because what happens is they are alone, they are isolated, there is so much of anxiety. So it is working as a multi-purpose. It is working as an anxiolytic. It is working to regulate the body clock. It is reducing inflammation. A lot of neuro-immune dysregulation which occurs because of a lot of stress. So according to me, the other thing which I tell my patients is melatonin is a very good adaptogen. So because it adapts, it allows our body, which is sick, to adapt to the invader better, because we need to handle the invasion of this virus better. And it allows the invasion to be limited. It draws a line, it draws a perimeter. And because it draws a line and perimeter, it doesn't allow the invasion. So it actually limits the disease. So these are all very nice to speak, but you need to tell the patient, as Dr. Agarwal said, it doesn't hurt. It's an adjuvant. So I also make it very clear that it's not a cure, but it is a very good adjuvant. The other thing which I want to say, and Dr. Agarwal will bear with me here, that it is very good. Lot of our post-COVID patients persist to get evening rise of fever because of a thermoregulatory dysfunction. Minute you add melatonin, this whole hypothalamo-thermoregulatory syndrome completely disappears. Not only that, they get an inappropriate tachycardia. They get fast heartbeat. which is a inappropriate tachycardia, which is called a sinus inappropriate tachycardia. Minute you give melatonin, I've seen that the sinus inappropriate tachycardia doesn't even need a beta blocker. So there are some autonomic benefits also of melatonin, just not thermoregulatory benefits. And I think the cardioautonomic benefits are also quite beneficial.
Thank you very much for that very clear commentary. Absolutely right. The underlying disruption of the circadian system cannot be overlooked. And as you say, melatonin has a major role in setting circadian rhythm, or as you say, winding the clock. So there may be other, in addition to the anti-inflammatory, antioxidant, and immunostimulatory effects of melatonin directly, there may be other benefits, particularly in terms of the circadian clock. Even 3 years ago, the Nobel Prize was given for chronobiology. This is not trivial. Disruption of your circadian rhythms has numerous effects on a lot of diseases. So they are obviously very important.
Thank you, sir.
Shant, we can, this is a wonderful presentation. And I only go back and finally to say one thing is India's Vedic sciences talks about Uttarayan and Dakshinayan. It is nothing but Amavasya and Purnima, the full moon and the new moon. This is nothing but an imbalance between and balancing the serotonin, melatonin in the body. If melatonin is low, increase it. If serotonin is high, reduce it. Or if serotonin is low, you increase it. So that imbalance of serotonin, melatonin is well described in our Vedic literature in terms of changes everywhere.
You're absolutely right. This imbalance has been reported many times and noted.
So we can close that. Shant.
Thank you, sir. Thank you so much for this wonderful session, sir. And I completely agree that our audience who have joined us here, which is around 3,000 doctors across India have joined us here for this session. And they must have definitely, I mean, they are having a lot, they had a lot of questions about melatonin, and I'm sure they must have got their answers. So thank you very much, Dr. Russell, Dr. Agrawal, sir, Dr. Shashank Joshi, sir. So thank you very much and have a nice day.
Thank you.
Thank you very much. And I'm going to get the email of all of you gentlemen, and I do want to communicate reference other information and publication of data and so forth. That'll be great.
Absolutely.
Thank you very much for allowing me to do this. It was enjoyable, and I hope it will turn out to be helpful. Be well, my friends.
Okay.
We will keep in touch.